Okay, so let's finish these topics fast. Okay, so yesterday we are done with this herniation syndromes. We have discussed 4 types of herniations: the cingulate herniation, then the downward herniation of the brainstem completely, then the uncle herniation. I told you the uncle is the most middle part of my this temporal lobe, right? And it compresses by cranial nerve 3. Okay, and initially you will get the contralateral symptoms because of the ipsilateral side of the compression of my these peduncles, and then I get the ipsilateral these symptoms because of the contralateral peduncle compression, right? And finally, we studied about the cerebellar tonsillar herniations, okay, and that can lead to the death of the patient. We have discussed all the motor neuron signs, and the important ones were the this atrophy one is very important. Babinski is important. Okay, the claxton reflexes and the pronoted drift. These 4 signs are very important to remember because every other you guys already remember. Okay, you already know about that. So remember these 4 signs; they were the important one. Okay, so today we will discuss the spinal lesions. Okay, and first we have the spinal muscular atrophy. Okay, that happens because of the degeneration of the anterior horns of spinal cord. We have discussed that previously in the biochemistry lectures when we're talking about all the spacosome complex. And I told you if you got a mutation in the SMN1 proteins, that means the defective SNRNBs, you will get a degeneration of the anti-spinal cord. And as a result, because in the anti-spinal cord you have the synapses and the and these lower motor neurons, right? So what you will get is the lower motor neuron neuropathy, right? You will get the atrophy of the muscles. Okay, the symptoms start in the lower limb and then progress to the upper limb and the upper part of the body. Okay, so it would be a symmetric weakness, lower motor neuron symptoms only. Okay, you will get the fasciculations. Hypotonia would be there, flaccid paralysis will be there, you will get the atrophy of the muscles. Okay, it is an autosomal recessive mutation in the SMN1 gene. Okay, and as a result, you will have a defective SNRNPs that are responsible for the spliceosome complex, and it is also known as the Werding-Hoffmann disease. Is that okay? We discussed that previously.
Yeah.
Just give me a second. Yeah. Now you have the amyotrophic lateral sclerosis, okay, in which you are having an atrophy of both the upper motor neuron fibers as well as the lower motor neuron fibers. Okay, so whenever in the clinical vignette you ever heard, ever hear this upper motor neuron signs as well as the lower motor neuron signs, you will always think about the amyotrophic lateral sclerosis. As you can see, for the upper motor neurons, you have the degeneration of the descending corticospinal tract, right? And for the lower motor neurons, you have the degeneration of the anterior horn, right? So both the anterior motor neuron, so both the lower motor neuron signs as well as the upper motor neuron signs, both are present. And please you need to know that the corticobulbar tract are gone early, and then the corticospinal tract. What does that mean? That all the muscles of your face and the neck, which are supplied by the cranial nerves, they will die early. Okay, and then those muscles which are supplied by the corticospinal tract, the descending corticospinal tract, they will die in the later stage. Okay, so the muscles supplied by the cranial nerve 5 that include all your facial muscles, for the these jaw muscles and the masseter. Okay, then the 7th nerve that supply all the facial all these muscles of your expression. The 9th, the 12th, and the 10th muscle also, right, supplying all your muscles for the swallowing of the food. So they will die early, and as a result, the patient cannot move their jaw, they cannot swallow anything, they will have the recurrent regurgitations, right? They will have a recurrent aspirations, and as a result, a recurrent aspirational pneumonia. Finally, when the corticospinal tract was damaged, okay, the patient will get the weakness of all these muscles of the periphery, right? And ultimately, they will have the involvement of the respiratory muscles. And when the respiratory muscles die, what they will have is low respiratory rate, okay, weakness in the respiration, and as a result, again, a recurrent aspirations will be there, okay, and that lead to the patient's death. And generally, when they come to know all these complications of the disease, they generally commit suicide. Okay, the patient may often commit suicide after knowing their diagnosis because of the complications of the disease and its suffering. Okay, so initially patient will have a loss of motor nuclei, Okay, and as a result, atrophy of the cranial nerve 5, 7, 9, 10, and 12. All these nerves have a motor supply, right? They are giving motor supply, so they will die first. Then you have a asymmetric muscle weakness. Please know it is not a regular pattern. It can, it can affect any segment of the spinal cord. In multiple segment, you can have multiple type of lesions among these four. Okay, so it would be an asymmetric type of muscle weakness. Okay, atrophy of muscles will be happening, and because of that atrophy, you will be having an increase in the creatine kinase level. The patient will become the wheelchair bound. In the later symptoms, a respiratory weakness will occur. Okay, and as a result, the patient will become too weak to cough. They cannot cough properly, right? They will have a recurrent pneumonia also. Dyspnea will be there. Respiratory infections will be there. Okay, so these are the symptoms for the amyotrophic lateral sclerosis. You are both having hyporeflexia as well as the hyperreflexia. Both the atrophy as well as spasticity of the muscles will be there. Okay, both things are there. Yeah, Stephen Hawking is the example. Okay, for the ALS, he had this disease. Okay, and yeah, why this thing is happening? It's happening because of a mutation in the superoxide dismutase. And does anyone remember the function of this enzyme?
Converts superoxide into water and oxygen.
Into hydrogen peroxide.
Okay, yeah.
Okay, and it is a zinc dependent also. So because of this defectiveness, you will have a reactive oxygen species, and that can lead to a damage of your neurons. And that's where the cell death is happening, right? You will have the flaccid weakness, fasciculations, atrophy, okay, bulbar palsy. I explained you what that means. All the motor supply of your face from the cranials, okay, and they will die. You will have the bulbar palsy, you will have a dysarthria, you cannot speak, you cannot swallow, okay, you cannot move your tongue because of all these cranial damage. Okay, you will have the locomotor neuroscience like the spasticity, weakness, hyperreflexia, clonus, pseudobulbar palsy, dysarthria, dysphagia. Again, the emotional liability will be there, and ultimately, a disease is fatal. Why disease is fatal? Because of the respiratory failure. Okay, and all these infections. These are the cause of death. Okay, and because of this fear of suffering, the patient generally commit suicide after knowing their diagnosis. Okay, so that's about the amyotrophic lateral sclerosis. Please note it is a asymmetric, although it is seeing a symmetric here, but all these lesions are happening at different segments of the spinal cord, right? Not on the same side. So you will always have the asymmetric kind of weakness, right? And you will also have the atrophy of the primary motor cortex. Okay, because all these lower motor neurons, they will be coming from the primary motor cortex, so they will die. Ultimately, you will have an atrophy of the primary motor cortex also, and no sensory symptom will be present in the ALS, and that is the very important thing. Okay, no sensory symptom, just the muscular symptoms will be there. Okay, any doubt?
No, thank you.
Okay, now you have the complete occlusion of the anterior spinal artery. Previously, we have discussed the all this occlusion of the anterior spinal artery, and I told you with the anterior spinal artery, what syndrome you will get. No one? Occlusion of anterior spinal artery. What syndrome you will get? What kind of a stroke happen? No one? Little medullary syndrome. Remember?
Yeah.
It wasn't the lateral. It is anterior. What
Medial,
branch?
right?
Yeah, what branch can cause a little medullary syndrome? I was taking you. What
Posterior
branch?
inferior
Yeah,
cerebellar.
pica, right?
Pica.
And what branch occlusion can cause a lateral pontine syndrome?
AIC.
Ica.
ICA. And the anterior ones are because of the anterior spinal artery and the basilar artery. Okay.
Okay, yeah.
So in the previously, I told you whenever you have an occlusion of the anterior spinal artery, you can have a damage of your this anterior medulla, right? But this anterior spinal artery is also present anterior to my spinal cord. Okay, and when the occlusion of this artery happen, actually this ASA is a branch of your abdominal aorta. Okay, and the previous one we have discussed are the branch of your vertebro-basilar artery, right?
Yes.
So vertebral basal artery, they will give the branches, the antispinal artery, similar time. Okay, the abdominal aorta also gives the branches of this antispinal artery. So they will join together and form a continuous blood supply. Okay, continuous column. So now in a scenario where you have this damage of the antispinal artery, a blockage, okay, because it's supplying all the anti structures up to the dorsal root. Okay, they all will die. All the gray matter will die. All the fibers running anterior to my dorsal root, they will die. That includes the corticospinal tract, okay, the spinothalamic tract, anterior and anterior and lateral both, okay. But as you can see, dorsal column is spared, and as a result, I will have a normal proprioception, okay, a normal proprioception, but a loss of all the senses, okay. I will have both upper motor neuron signs as well as the lower motor neuron signs, and they will be symmetric, okay. So if I want to differentiate it with my ALS, because in both ALS and this ASA artery occlusion, I'm having both upper motor neuron as well as a lower motor neuron sign. Okay, so first thing will be the symmetric and asymmetric. Okay, these symptoms will be bilateral, but the symptoms should be alateral in case of ALS. Second thing is the presence of sensory symptoms. The pain and temperature loss will be there in the ASA occlusion, but not in the ALS. Okay, so you will have a sparing of the dorsal columns. That means you can still have the proprioception. You won't have any Romberg sign, because I told you whenever you have a loss of proprioception or loss of cerebellum, you can have a Romberg sign, right? So you won't have any Romberg sign in that. Okay. And what about this Lissauer tract? Okay, so what happens is, if your hand is supplied by dermatome C1, for example, okay, then this C1 and the C7, the nerve fibers from C7, when they enters my spinal cord, they will run upward, okay, connecting all the C6, C5, C4 with them. So the nerve fibers which are supplying my C7, okay, they're actually are present from, they actually can stimulate, okay, all the C7, C7, C6, C5, and C4, okay, 4 spinal column upward. Okay, they will run like that. If I draw that, if this is your one spinal cord segment, okay, this is the second one, this is the third one, and this is the fourth one, let's say. Okay, you have the C7 here, okay, you have C6 here, okay, this is my C5, and this is my C4. So what actually happens if the hand, let's suppose, and I told you already that hand is supplied by 3 dermatomes. What were they? In the hand, we have 3 dermatomes.
C7, C8, T1.
Not a T1.
C7,
Not a T1. C6, C7, C8. And the extreme ones, the C5 and T1, are only present in the forehand and arm, right?
Yeah.
Okay, so and where does my C7 present? In the lateral, or in the medial, or in the extreme medial? You must remember all these dermatomes. They will ask you.
Lateral forearm.
In the medial part, you have the C7. At the lateral, you have C6. In the most medial, you have the C8. Okay.
Okay.
So the middle part of your hand supplied by the C7. Now, what happens when the C7 fibers reach here? Okay, along with synapsing at that part, they also synapse in the C6, C5, and C4. Okay, and you know that all these fibers are also, all these fibers are also forming this arc for my muscles for the reflex, right?
Yes.
Okay, now what happens? So these fibers are supplying all the muscles in the C7, C6, all the motor neurons from my C7, C6, C5, and C4. So in a scenario if I got some kind of a heat damage or any kind of a damage, okay, and in that scenario, along with the stimulation of my C7, I will also get the stimulation of C6, C5, and C4. Okay, for example, if it is a very hot pan here and my hands about to state, okay, that along with the stimulation of C7, I will also get the stimulation of C6, C5, and C4, right? And as a result, all the muscle groups supplying by C4, C5, C6, and C7, they will be stimulated and they will simultaneously draw my hand backwards, right, away from the pen. That's how I get this kind of a reflex, because of the stimulation of large muscle group, right? And that is possible because of the Lissauer tract. Is that okay?
Yes.
In order to withdraw your whole hand, you need not just one muscle but a group of muscles, and that will be stimulated by this Lissauer tract. And because it is giving off by the C7, it also gives off the C6, C7, C4. Okay, so that happens. So the Lissauer tract and my dorsal columns will be spared. Okay, and yeah. So this artery supplies the ASA below the T8. Doesn't matter actually. Okay. Now it can generally be caused by the repairing of the aortic aneurysm, because I told you that all these arteries are supplied by the abdominal aorta. Okay. Then at the time of your aortic aneurysm repair, you can have the blockage or any kind of embolus in these arteries, and as a result you will have a blockage. So it will always be a scenario in which the patient has a recent surgery of the abdomen for the reparation of the abdominal aorta, and now after 3-4 days later he's having this kind of a embolus, right? This kind of symptoms. Okay, symptoms include the damage in the corticospinal tract, okay, and that would be the upper motor neuron lesions. Patient will get the spasticity, okay, hyperreflexia. Patient will also have the lower motor neuron lesions at the level of lesion. That means if it is my C7, I will get the lower motor neuron symptoms at C7, and I will get the upper motor neuron symptoms below the C7. Are you getting my point?
Yeah.
Because all these fibers are running downward. So if this part is inhibited, no information can be given from my cortex to lower parts, right? Because it is gone here. It is kind of is damaged here, right? So yeah, so no fibers can go from here to here, and it will get the loss of all the kind of this information, right? So upper motor neuron lesion, it is below the lesion, and a lower motor neuron deficit is present at the level of my lesion. You will also, because of a damage in the anterior and the lateral spinothalamic tract, you will get a loss of all the pain and temperature. Okay, and is it contralateral or at the same side, ipsilateral?
Both sides will be affected
And how does both sides?
because anterior spinal artery is supplying both sides of the spinal cord. So
No,
both.
I mean, if I got a damage in my this lateral spinothalamic tract, what kind of a damage I will see? Lateral or
Contralateral.
contralateral? Yes, and because of a damage in my anterior horns, I will get the ipsilateral. So it would be an ipsilateral lesion, okay, at the level of my lesion, okay, and it would be a loss of all the pain and temperature contralateral to my side of body, okay, below the level of lesion. Is that okay? So same side at the side of my lesion, okay, and opposite side below the lesion, just like my all these muscles. Sure.
Could you please repeat what is lost by the of the contralateral side, the sensation or the muscle?
See, let me tell you this. You have all these fibers running from my dorsal like that, right? All the pain and temperature fibers, right? They're
Right.
running here, and then they crosses after synapsing, right? They crosses, okay,
Right. Yeah.
and they enters the lateral spinothalamic tract, and then they rub this upward direction,
Right.
right? Now, what happens is whenever I got a damage, Okay, let us suppose at the level of my lesion. Okay, at the level of lesion, because this gray matter is being destroyed, you will get the ipsilateral symptoms, right?
Yeah.
If there is spinal cord above it like that, okay, in which you're also and this is absolutely normal, right? All the fibers are running this direction also from downward,
Yeah.
right? Same fibers. If this part is disrupted, what will happen? No information can be given from all your hands and limbs to the brain.
Right.
So at the level of lesion, you're having a ipsilateral symptoms. Below the level of lesion, you're having a contralateral symptoms, right?
Right.
That was I talking about.
Okay. Thank you.
Okay. And for my muscles, because all these fibers are running downward in the posterior let me remove it. Yeah, all the muscle fibers are running in the posterior spine, the corticospinal tract, right? Like that. And at the level, okay, they all will enter into the anterior horns, synapse here, and then gives up the muscles, right?
Yeah.
So at the level of lesion, as you can see, I'm having a lower motor neuron lesion, okay, and below the level of lesion, because all these fibers are running downward, if they get that this time this happened here, then no information can be given from my cortex to my lower parts, right? And I will get a loss of the upper motor neuron fibers, right? So below the level of lesion, upper motor neurons; at the level of lesion, lower motor neuron.
Yeah.
Okay. And does it be ipsilateral damage or a contralateral damage?
Ipsilateral for both.
Ipsilateral, because and at the medulla they have the crossing over, right?
Yeah.
So only after the medulla I can get a contralateral damage. Below the medulla I will always get the ipsilateral damage. Okay. So any doubt on the complete occlusion of antispinal artery?
No, thank you.
So just look for the symptoms. If the patient is having spastic paralysis below the level of lesion, okay, and there's flaccid paralysis at the level of lesion, loss of temperature, and all these things bilaterally, think about the ASA occlusion. Then you have the tabes dorsalis, and it is caused by the tertiary syphilis. Actually, it can cause by any stage of the syphilis, primary, secondary, and tertiary, doesn't matter. So how will you differentiate the primary and secondary stage with the tertiary stage?
Tertiary will also include cardiovascular symptoms.
Exactly. These are the cardiovascular symptoms which are specific for my tertiary syphilis. Okay, neurosyphilis can happen in any stage. Okay, but the severe syphilis, it will only happen in the tertiary stage. Okay, that is important point. Now, because of my because of my syphilis, I can get the tabes dorsalis, and in this condition, I'm having a damage of my dorsal columns along with the dorsal roots. Now look, what are the function of my dorsal roots?
All sensations.
All sensations, including all my muscle reflexes, pain, temperature, perception, right? And if these roots are get damaged, can any muscle, this muscle spindles or my all these Golgi tendon, these bodies, can they send signal to my brain or spinal cord?
No.
No. And as a result, what kind of reflex I get? Hyperreflexia or hyporeflexia?
Hypo.
Hyporeflexia I will get. I won't get any reflex. Okay. But can I get the atrophy of my muscles because of a dorsal disc root damage?
No.
Why?
Because the lower motor neurons are still intact.
Exactly. See what actually happens. For the contraction of your muscles, okay, you have these roots. Okay, first the posterior, the corticospinal tract. Okay, and then you have these anterior horns, and then the muscle gives, right? Then the brainstem muscles gives the lower motor neuron, and these are the upper motor neurons, right?
Yeah.
Now, for the muscle reflex, I have first the spindle. Okay, these muscle spindles, they will send the uh, uh, all uh, all these accessory fibers, right? And they travel through my dorsal root. Okay, in the dorsal root, they build these Ranschau shells, right? They will be stimulated. Okay, and they will give the inhibition to the muscle, right? Remember the muscle pathway, reflex.
Yeah.
Now, what happens if these parts are damaged? I will get the loss of reflexes. Okay, but the signals which my cortex was sending initially, it is absolutely normal. The signals from my cortex, they're absolutely normal, right? So I won't get any atrophy, but I will get the loss of reflexes only. Any doubt in that part?
No, thank you.
Okay, so in the tabes dorsalis, I'm having a damage to my dorsal columns as well as the dorsal root. Because of a damage in the dorsal root, I will have loss of all kind of senses, including the pain and temperature even. Okay, because of a damage in my dorsal roots, these dorsal columns, I will have a loss of my proprioception. That means I cannot sense where my body part is right now, my hand in the air or on the table, right? I can't sense that. And because I can't sense that, okay, so patient will have a recurrent kind of, a damage from the surfaces of all these objects, okay? And importantly, they will have the Romberg sign, because for the balancing, you need to sense the environment, right? Your muscles need to sense the environment. If they cannot sense the environment, if they cannot sense their position, then you cannot maintain the posture, right?
Yeah.
If you cannot maintain the posture, you will get the ataxia. And that's exactly what happens in the Romberg sign. You will ask the patient to close the eye and then stand. Okay, if they stand properly, then it is a raggedy Romberg sign. If on closing the eyes, because you only by two ways you can sense uh, where you are right now, and it is by the eyes, and second by feel from the hands, right? From the eyes, if they look, it will be absolutely normal, but as soon as you ask them to close the eyes, they cannot maintain the posture and they will fall. And this is the Romberg sign, and it is positive in the tabes dorsalis because of the poor coordination. Because of this loss of all the proprioception. You will have an absence of the deep tendon reflexes. Okay, you will have a sensory ataxia because of the impaired proprioception and poor coordination again. You will have a demyelination of the dorsal columns and the dorsal roots, right? It is also associated with the Charcot joints, which are a symptom of my syphilis. Okay, you will have a very stabbing kind of pain. Okay, and the shooting pain will be there. Argyle Robertson pupil, you guys already know that the pupil will constrict on the accommodation, but it won't constrict on the light, right?
Yeah.
And where what is the other condition where you get the Argyle Robertson pupil? What was the other condition where you get this Argyle Robertson pupil? No one? Pinealoma, remember?
Yeah.
Yeah.
Don't forget that, okay? Only in two conditions you will get the Argyle Robertson pupil. One is the tabes dorsalis and second is the pinealoma, I told you, right? So remember that. Okay, so yeah, a direct damage to my these dorsal columns and the dorsal roots happen. You will get a loss of deep tendon reflexes. Okay, muscle power will be totally normal. Okay, muscle you won't see any kind of atrophy of the muscles, but the deep tendon reflexes, they will be gone. Okay, because the reflex pathway is not damaged because of a damage in the dorsal root ganglions and these dorsal roots, of course, right? So symptoms like the loss of DTRs and the loss of proprioception. Okay, and you will think about the tabes dorsalis. Any doubt?
No, thank you.
No, thank you.
Then you have the syringomyelia. We have discussed that already. You will have a central cavity. It will expand syrinx. Okay. First, it will cause a damage of all the pain and temperature fibers because they take the crossing over here. As the cavity expand, you will have a damage of the anterior horns. You will get a lower motor neuron signs. When the cavity further expands, you will get an involvement of the posterior, this corticospinal tract, and finally the posterior column also. So at the very initial, because you're having a damage to the, all the sensory fibers, okay, fibers for the pain and temperature specifically, okay, so you will have a loss of pain and temperature bilaterally. And at that time, patient will always present you at that condition. They will have the loss of senses bilaterally in both the hands. They cannot feel pain. Okay, they cannot sense temperature. Okay, so basically they will burn hand while cooking the food recurrently, and they won't notice it until they see it with their eyes, right? That kind of a history patient will present you. You will think about the syngiomalia. Okay, damage to the anterior wide commissure of the spinal of this spinothalamic tract. You will have a bilateral symmetric loss of pain and temperatures. It is generally seen in the Chiari malformation 1. And what condition is associated with the Chiari malformation 2?
Myelomeningocele.
Myelomeningocele. Good. And what condition is associated with my Dandy-Walker malformation?
Non-communicating hydrocephalus.
Yeah, that would be present with any of these disorders. Any other neurological symptom or disease or any kind of problem associated with the Dandy-Walker malformation?
Spina bifida.
Spina bifida. Yes, spina bifida. Okay, so remember that also. So for the Chiari malformation 1, you have the syngiomalia. For the Chiari malformation 2, you are having the myelomeningocele. For the Dandy-Walker malformation, you are having the spina bifida. Okay, so it's nothing but just you will have a bilateral loss of pain and temperature, and then the muscle loss will happen. Then finally the proprioception loss will happen if the condition got untreated. But that generally don't happen. Okay, early diagnosis lead to just a loss of all these pain and temperature fibers and nothing else. Then comes the vitamin B12 deficiency. We have discussed that previously. We'll get a subacute combined degeneration syndrome. You will have a demyelination of the posterior columns. As you can see, you will have a demyelination or degeneration of the spinothalamic tract. Sorry, the corticospinal tract. And you will also have the damage of the spinocerebellar tract. So 3 tracts are damaging: the dorsal columns, okay, corticospinal tract, and the spinocerebellar tract. Because of a damage in my dorsal columns, okay, and the spinocerebellar tract, I will get the ataxia. Patient will also get the rhombic sign positive, just like my tabes dorsalis, because of a damage in the dorsal columns. Okay, patient will get the spastic paralysis bilaterally. It will be a symmetric, or I can say a bilateral spastic paralysis. Okay, no sensory symptom like pain and temperature will be seen. Okay, so a damage or a demyelination in the spinocerebellar tract, little corticospinal tract, dorsal columns, and the and that would be all. So we'll get the ataxic gait, we'll get the paresthesias. Okay, you will get the impaired position and vibration signs, and that leads to a positive rhombic sign. Okay, upper motor neuron symptoms will be there, not a lower motor neurons. Very important. Okay, and just like my tabes dorsalis, sometimes you can also get an involvement of the the dorsal roots also. And because of that involvement, you can also have a loss of deep tendon reflex, just like my tabes dorsalis. Okay, very important. Any doubt on the subacute combined degeneration syndrome?
No, thank you.
No, thank
Patient
you.
will have some kind of a history like megamastic anemia. They will have a history like gastrectomy or dilated resection, or the typhalobotrium blatum, or the vegan diet. All these kind of a history will be present with the patient. Okay. Finally, you have the Kodak-Koena syndrome. Okay. Kodak-Koena, like I told you, what does this term means?
Horsetail.
Horsetail. All the fibers. Okay, because the spinal cord will be at the L2 level, right?
Yeah.
And
Yes.
what does this and part of the spinal cord known as at the L2?
Conus medullaris.
The conus medullaris. After the conus medullaris, all these spinal nerves, like all these lumbar and the sacral spinal nerves, they will originate from this Kodak-Koena. They will, all these nerve fibers will be running down, and then they exit from the respective spinal cord. From the respective spines, right? So this is known as the Kodak-Koena syndrome. So see, if I have any damage in the Kodak-Koena, does I have the upper motor neuron lesion or the lower motor neuron lesion?
Lower motor neuron.
Lower motor neuron lesion, because no spinal cord is present here. All the nerve fibers are only present. So I will get first the lower motor neuron lesion. Okay. Should it be unilateral or should it be bilateral?
Unilateral, I think.
It is mostly bilateral. Okay. No, do know that. Okay. And in case of my the conus medullary syndrome, it is mostly unilateral. Okay. And you will have a loss of all the pain, all the temperature, all the vibration senses, right? All the muscle fibers. Okay. They will get damage in the caudate conus syndrome. Okay. It often happens due to this intervertebral disc herniation or a tumor. Sometimes you will have a radicular pain, just like we've discussed previously. Whenever you have a nerve compression, you can have the shooting like pain, right?
Yeah.
And this pain travel all the way down to your leg in all the regions supplied by that nerve root, right? All the dermatome. So it will be a radicular pain. You will have an absence of the knee and the ankle reflexes. Why?
Because the lower motor neuron is getting damaged.
Yeah, and you have the damage in the L4, L3, L2, right? And also because all the fibers running downward, they will get tired. You will also have a loss of, sometimes the S1, S2, S3, and S4 also, right? And those, the S1, sorry, the L5 and the S1, they supply the ankle, right?
Yeah.
If they die, you will have the ankle loss of ankle reflexes. L2, L3, and L4 will die. You will have a loss of the knee reflex. Okay, because the pudendal nerve is supplied by the S2, S3, and S4. If that die, you will have a loss of the bladder and the anal sphincter control. And because of a loss in the anal sphincter control, what you will have? Fecal
Absent wing
incontinence or
reflex.
retention. Yeah.
Incontinence.
It will be a fecal incontinence. But you also need to remember that the all these parasympathetic nerves from my sacrum, they're also supplying my GIT, right? The pelvic
Right.
splanchnic plexus. If the sacral roots die, the pelvic splanchnic this plexus will also die.
Yeah.
As a result, the parasympathetic supply to what part of my gut will lost?
Hindgut.
Hindgut. That include all from the splenic flexure to up to my rectum, right? So as a result, I will also get the fecal retention because I need the parasympathetic supply for the defecation, right?
Right.
So fecal retention will be there, and sometimes fecal incontinence will also occur. Okay, you will have a loss of all this, all the smooth muscle, the tone of the smooth muscles of my external sphincter. It will be lost. Okay, along with that, you have the fecal retention. So fecal retention, along with the loss of tone of the external anal sphincter, you will think about a damage of the sacral roots. Is that okay?
Yes.
You will have a loss of bladder, so you will have a urinary incontinence also. Okay, and the saddle anesthesia will be there. Okay, so these are the symptoms of the cauda equina syndrome. Any doubt?
No, thank you.
No, thank
Now
you.
you have the multiple sclerosis in which you are having a demyelination randomly, right? It is not in a specific order, just like my ALS. Remember?
Right. Yeah.
Yes.
In my ALS, I'm also having a kind of a random demyelination. In my multiple sclerosis, I'm having a random demyelination, right? And asymmetric also. So how can you differentiate between the multiple sclerosis and the ALS?
ALS will have low motor neuron symptoms also, but MS will only
Yeah.
have UMN.
Yeah, in case of my multiple sclerosis, I'm only having the upper motor neuron lesion because it will be a CNS damage. In case of my ALS, I'm having a CNS along with the PNS damage, right? So both upper motor neuron as well as the lower motor neuron symptoms will be there. What other vitamin deficiency can cause the subacute combined degeneration syndrome?
Vitamin E deficiency.
Vitamin E deficiency, exactly. And what other disease can present me just like the vitamin B12 deficiency, the subacute combined degeneration, other than the vitamin deficiency?
Cystic fibrosis?
Not cystic fibrosis, no. What other disease can lead to vitamin deficiency? That's not my question. What other disease can cause the subacute combined degeneration like syndrome, like symptoms. What other disease can cause it? Yeah,
Friedreich's ataxia?
yeah, Friedreich's ataxia. Okay, so remember the three diseases: the vitamin B2 deficiency, vitamin E deficiency, and the Friedreich's ataxia. Okay, these three will cause the symptoms just like my subacute combined degeneration. Okay. Okay, now you have the poliomyelitis. Okay, that happens because of the polio virus. And what kind of a virus is it?
RNA
What?
virus.
Yeah, RNA virus. What family does it belong to?
Picorna?
The picorna virus family. Okay, do remember that. Okay, basically what happens whenever you acquire this infection, first the virus will replicate in the oropharynx and the small intestine, because you guys know that this virus is acquired by the fecal-oral route, right?
Yeah.
Because it do not have any kind of an envelope, so it only has this inner core, and which is uh, having very high resistance to all the surroundings, right? So it can be transmitted by the fecal-oral route, right? So it replicates in the oropharynx and the small intestine, and then it enters to your bloodstream, and from the bloodstream it reaches to your CNS. In the CNS, it first go to the spinal cord, and entering the spinal cord, it will destroy the anterior horn of the spinal cord. So you will get symptoms just like my spinal muscular atrophy. Is that okay?
Yes.
So how can I differentiate between the spinal muscular atrophy and my poliomyelitis?
History.
Yeah, again, history of the patient is important. The immigrant status is very important, because you won't get this disease in the United States nowadays. It is only present in the immigrants. Okay. And this floppy baby syndrome, it will be present since the birth, right? And that happens in a child. So it will be a child who is absolutely normal up to 4, 5, or 6 years, and then he started having this kind of atrophy. But in my previous syndrome, the spinal muscular atrophy, or having the muscle atrophy at a very early stage, right? And the history of other family members is also very important. If some other family members has similar kind of history, it will confirm the diagnosis of my Warding-Hoffmann syndrome, right?
Yeah.
So that kind of a hint you must look for. So in case of poliomyelitis, you're having the death of the anterior horn, so it would be a lower motor neuron death. You will have a element signs like the asymmetric weakness or symmetric weakness also. Okay, doesn't matter. Asymmetric and symmetric both could be there. Okay, I got an endemic question in which both side of the muscles will be dying, right? So both asymmetric and symmetric weakness can occur. You can have a hypoglonia, flaccid paralysis, fasciculations, hyperreflexia, muscle atrophy. Ultimately, the respiratory muscles will involved, and you will get a respiratory failure. Okay. Along with this paralysis, patient will also get the fever, headache, nausea, and malaise, and these are the symptoms of the infection or the inflammation, right? So signs and symptoms for the infection will be there. Signs and symptoms of the damage of the anterior horn will be there. On the CSF examination, you will be seeing a high WBC count, increase in the protein, okay, with no changes in the glucose. Just like a viral meningitis, you will have a symptoms like the viral meningitis. You will also get the headache, okay, and yeah, the virus can be recovered from the stool or the throat. And if you guys go back to the microbiology session, we have discussed one virus that can cause a lower motor neuron signs also. Does anyone remember the name?
Coxsackie.
Not the Coxsackie virus. It cannot cause a neuropathy. The West Nile virus, remember? Have you guys heard that name? West Nile virus?
Yeah.
Yes.
Thank God. Okay, so in case of my West Nile virus, I'm having both the upper motor neuron symptoms as well as the lower motor. And mostly I have only the lower motor neuron. Although, like any other viral meningitis, it is causing the viral meningitis. But unlike any other viral meningitis, in case of my this West Nile virus, I'm having a lower motor neuron symptom also. right? Only, not also, only the lower motor neurons. So tell me, how can you differentiate between the poliomyelitis and the vaccinal virus meningitis? Because in both the case, I'm having a CSF which is showing the high WBCs, increase in protein and normal glucose. That means all the signs of viral meningitis like headache, fever, CSF will be there. Signs of lower motor neuron lesion will be there, could be asymmetric, could be symmetric in both the conditions. So how can you differentiate between the poliomyelitis and the vaccinal virus?
West Nile also has like a predisposition for like bone breakage, maybe.
Okay, an outbreak could be there, outbreak in a locality. That could be a hint. But a same kind of a outbreak can happen in my this condition also, the poliomyelitis also. If there's a
It's
lots of, let us suppose it is a case of this immigrant patient, okay, and now he's having this, kind of all this paralysis thing and the fever, and the WBC count will be high, protein will be high, glucose normal, and in their locality from where they immigrated, they have this kind of a outbreak, like 2 3 children are also involved in that. So what you will say, whether it is a vaccinal virus or a poliomyelitis?
West Nile,
Okay, and how can you say that?
probably because polio virus takes time to show its symptoms.
Okay, it would be 2 week symptom, 3 week, the time will be enough for both the diseases.
West Nile virus, does it? I don't think it has a vaccine, right?
No, yeah, it don't have any vaccine. That's why I told you that both the cases are immigrant. Although vaccine, if the examiner tell you that the vaccine that this patient is belong to a native US, okay, no immigrant history, then you can be 100% sure that the patient is having a vaccinal virus infection. But if the examiner told you that the patient is an immigrant, so now you cannot be sure whether he has this vaccine or not, right? There's no point of vaccine then.
Would you have to check for protein from the West
In both
Nile?
the conditions, you're having a high protein count. They won't tell you that it is specifically a vaccinal, of course. They want you to know that it is a vaccinal or it is a poliomyelitis. So they will just give you a patient who is having a paralysis, who is having the headache, and all the signs and symptoms of the viral meningitis. And they tell you that, in their locality, 1 or 2 children also had similar kind of outbreak a week before or a 2 week before sometimes.
Breaking bones is seen in West Nile virus.
No, vaccinal is not a dengue, so you won't get any breaking bone. Actually, there is no way you can differentiate between the two. Okay, I tried so many searches, read so many papers. None of the none of the paper ever mentioned any difference between these two viruses. Okay, so whenever you look for the immigrant status, okay, and all of them are the children only. Think about the poliomyelitis. Whenever you have the immigrant status and multiple age groups are affecting, okay, old age, young age, you can bet it could be the vaccinal virus, it could be the poliomyelitis, but mostly it would be the vaccinal virus if the old age population is affecting. If the patient is from the US only, no immigrant status, then you can be 100% sure that the patient is having a vaccinal virus infection. Okay, although these totally are the guess only. Again, no any trick for the differentiation. So yeah, just look for that. Before choosing the option, you need to make sure that it is not a vaccinal, it is a poliomyelitis, or it is not a poliomyelitis but a vaccinal. Okay, because in the exam you have both the options, so it is kind of a hard to differentiate between the two. I think it was NBME 23 or 21 who has that kind of a question, and yeah, I never found any specific answer for that. Okay, so look for that. Again, if you guys found any solution to that problem, please will let us know also. Okay,
Yeah. Okay.
so for and up to that point, just think whenever you have only children which are affected, think about the polio immigrant only. Okay, if you have the native US patient, then it will be 100% a vaccinal virus. It would be a immigrant, but multiple age groups are affected, like old age, young age, and the children. think about the poliomyelitis. Think about the vascular. Okay, that kind of a symptoms and the history of the patient must look for. Then you have the Brown-Sequard syndrome, in which you are having a loss of, half segment of the spinal cord. Okay, you have one spinal cord segment, and half of this spinal cord is now gone. So what kind of a symptoms you will get? Now, see, at the level of lesion, first you're having a damage of the anterior horns, so you will get the lower motor neuron lesion. At the level of this lesion, right, you will have the lower motor neuron signs. You will have, because all the fibers from the pain and temperature, they will be running here and crossing over is happening here. So at the level of lesion, I will get the ipsilateral loss of pain and temperature, right? And I will get the ipsilateral loss of proprioception also, because of this dorsal column damage, right?
Yeah.
So at the level of lesion, I will be having a loss of all the senses ipsilaterally. At the level of lesion, I'm having the ipsilateral lower motor neuron signs. Now, below the lesions, you have this posterior corticospinal tract, the lateral spinothalamic tract, and when they got damage, okay, because of a damage in the posterior, the corticospinal tract, you will be having ipsilateral upper motor neuron signs below the level of lesion. Is that okay?
Yeah.
Now, because of a damage in the spinothalamic tract, you are having a contralateral loss of pain and temperature below the level of lesion.
Right.
Is that okay? Now, because of a damage in the dorsal columns, you're having a ipsilateral loss of vibration, position, and touch. Is that okay?
Yeah. Yeah.
So at the level of lesion, lower motor neuron signs and loss of all the senses. Below the level of lesion, you're having on the contralateral side, the loss of pain and temperature. Ipsilaterally, the loss of perception and the upper motor neuron signs, and that is your Brown-Sequard syndrome. If the lesion happens in the, in all these up to level of T1, because sympathetic fibers are running from here, right? And especially all the fibers for the Horner syndrome, right? The oculosympathetic pathway. Okay, all these fibers will be exit at the T1, up to the T1, right? So up to the T1, if you have any kind of a lesion like the Brown-Sequard syndrome, you will also get the ipsilateral Horner syndrome. Is that okay?
Could you?
Sorry, I couldn't hear that. Is that okay? About the Horner syndrome? See, see, you have this hypothalamus. Okay, then you have the brainstem. Okay, then you have the spinal cord. Okay, and finally the sympathetic ganglia are there. Okay, the fibers for the descending hypothalamic tract, which can also cause the Horner syndrome. See, this Horner syndrome happens because of a damage in the descending hypothalamic tract, and as the name suggests, this tract is start in the hypothalamus. Is that okay?
Yeah.
Now these fibers will descend downwards, okay, crossing all your this brainstem, entering the spinal cord, okay, and in the spinal cord the fibers start exiting, okay, and all the fibers exist this exit up to the level of T1. Okay, this is a T1 level. At that level, all the fibers for my the descending hypothalamic tract, or you can say the fibers for the Horner syndrome, okay, they got exit at the T1. Okay, then they enter all these sympathetic ganglia, okay, and finally they go to the face or the eyes, okay, for the lacrimation, for this pupillary the dilation and all these things. Okay,
Yes.
if I got a damage in the spinal cord up to the T1, up to here, I will get a loss of ipsilateral descending hypothalamic tract.
Right.
And because of that, I will get the ipsilateral Horner syndrome. Okay. The similar syndrome I will get if I got a damage in the brainstem also, if you guys remember.
Yeah, yeah.
Right. In the lateral medullary syndrome or in the lateral pontine syndrome, I'm having the Horner syndrome also, right? Why? Because all these fibers are also crossing my brainstem, right? So do remember that up to the T1, if this kind of a lesion happens where I'm getting a loss of unilateral spinal cord, a segment of a spinal cord, in that case, I will also get the ipsilateral Horner syndrome along with all these 5 symptoms. Now, any doubt on the Bouncica syndrome?
I have one question.
Yes.
Since the sympathetic outflow is thoracolumbar, do
Yes.
the nerves arise? If I'm considering sympathetic fibers, do they arise from the spinal cord even before T1?
Sorry, I didn't understand you.
Like you showed on the diagram that nerves of sympathetic fibers, they are
Yeah.
arising from the spinal cord
Yes.
even above the level of T1. Like, does that happen because sympathetic fibers only come out from thoracolumbar region? So does it also come out from the cervical region?
Sympathetic pathway. Yes, of course, they have to descend from from all this part also, right?
Yeah, but do they arise from the level of spinal cord also? Like, do they come out of the spinal cord even in the cervical region?
Sorry, I'm not able to understand your question actually.
Okay, I'll ask it later. I'll ask you on WhatsApp.
Yeah.
I'll send you a diagram.
Okay. Yeah. Yeah. Okay. Okay. That would be better. Okay. So finally, you have the Fredis ataxia. Any more doubt on this Brown-Séquard syndrome? This will I will clear on the WhatsApp. Okay, don't worry. I will get the answer. Any more doubt on the Brown-Séquard syndrome?
No, thank you.
Okay, now finally you have the Fredis ataxia. Okay, that is an autosomal recessive disorder, and which just like the Huntington disease, okay, you will have the expansion of the GAA. What other triangular expansion if disorders are present that you must remember?
Huntington's chorea.
Huntington's chorea is the one. What? The myotonic dystrophy is the second, CTG. Fredis ataxia is third. And
Fragile X.
Fragile X syndrome. And in that, what was happening? What repeats were happening?
CGG.
Yeah, exactly. I think it was GCC or CGG.
CGG.
CGG, okay. CGG repeats. Okay, so do remember these four disorders in which you are having the expansion of the triangular repeats. And why does this expansion happening?
Slippage.
Slippage phenomena, yes, DNA slippage phenomena. Now, because of this expansion, you're having a damage in the gene, which is the frataxin, which codes for the frataxin. And the frataxin is actually an iron binding protein. Now, because of this loss of frataxin, you're having the impairment in the mitochondrial functioning. And now all these cells which require a high metabolic demand of oxygen, okay, high need of ATP for the ETS, these cells will suffer first. And that include your brain, your CVS, right? So the brain, the CVS, they will die first. Okay, you will have a degeneration in the lateral corticospinal tract that causes the spastic paralysis. You will have the damage in the spinocerebellar tract that causes the ataxia. The dorsal columns will die. You will have a loss of vibration senses. And please note, it is not a demyelinating syndrome. It is a degeneration completely. In the previous disorders we have studied, you're having a demyelinations, right?
Yeah.
Yeah.
But this is a degeneration, not a demyelination. You're having a death of the neurons, totally. Okay, the dorsal root ganglia will die, and that can lead to a loss of deep tendon reflexes also. The patient will have a staggering gait, frequent fallings will be there, nystagmus will be there. Okay, he cannot speak properly, slurring of the speech, dysarthria will be there. Pes cavus, and does anyone remember any other disease where having a pes cavus? The high arch
Marfan.
foot. Marfan is having a flat foot.
Charcot Marie.
Yeah, the Charcot-Marie-Tooth disease, you're having a pes cavus in that, right? Okay, then the hamartos will be there. Okay, just like my Charcot-Marie-Tooth disease, which is having a extension of all this. The toe will be there. Okay, the complete extension of the toe will be there. You're having a diabetes mellitus also because of a death in the pancreas. You're having a hypertrophic cardiomyopathy, and that is the cause of death. Okay, the hypertrophic cardiomyopathy will lead to the death. The patient can also have the kyphoscoliosis, as you can see. Okay, this is the kyphoscoliosis where you have the abnormal curvature of your spine. Okay, So yeah, that would be there. So just remember, the subacute combined degeneration syndrome like things will be there. Along with that, you're having a hypertrophic cardiomyopathy and the diabetes mellitus. Rest all things are same. It would be a child of age between 5 to 15 years. Okay. And yeah. And does anyone know why this kyphoscoliosis is happening?
Because of loss of proprioception.
How does proprioception can cause the kyphoscoliosis? I
Oh,
mean, it can surely cause the falls, but how does it cause the this kyphoscoliosis?
or maybe due
Abnormal,
to
yeah,
muscle atrophy because of corticospinal tract.
exactly. Because of the paraspinal muscles, you're having the muscles around the spines, right? Because of the asymmetric kind of atrophy, okay, in these muscles. Because of this atrophy, you're having, abnormal contraction of the muscles, right? And because of that abnormal contraction, you're having this kind of the curvature of the spine. Is that okay?
Yeah, and is this the same reason why we find kyphoscoliosis even in B12 deficiency?
Yes.
Okay, yeah, thank you.
Okay, so remember the subacute combined degeneration syndrome first. Okay, the diabetes mellitus second, hypertrophic cardiomyopathy, and symptoms like a Charcot-Marie-Tooth disease that include the Pascavus and the Hamarto. So this disease resembles 2-3 other diseases also. So whenever you encounter such kind of a patient and encounter such options also, you need to be able to differentiate between these 2-3 diseases also, right? The subacute combined degeneration and the Charcot-Marie-Tooth along with the Freitas ataxia. Any doubt?
What's the meaning of staggering gait?
It's just like the frequent falling will be there in the patient. Okay, it present with the frequent falling. Okay, the patient will just like move and then fall and then stumble and then move and then fall. Just a fancy term. Okay.
Okay, yeah, thank you.
So any more doubt?
No, thank you.
Okay, then you have the common cranial nerve lesions that you must remember, because whenever you hear any of this nerve lesion, they will ask you what what kind of a symptom you will get because of this nerve damage, and these are the important one that you must look for the kid for the fifth nerve damage, and that is your this mandibular nerve. Okay, because this nerve supply the muscles of the jaw. Because of a damage in the mandibular nerve, you can have a jaw deviation towards the side of lesion. Okay, because if this is your jaw, okay, then the right side nerve pushing the jaw on the left side, and the left sided nerve pushing the jaw on the right side. Okay, so in a scenario, if you have this left side nerve damage, you will have the deviation of the jaw on the left side, right, the ipsilateral side. So please note the jaw deviates towards the side of